Hello, I'm Dr. Wanda Torres, MD. I am the founder of Suncoast Women's Care, a medical facility renowned for our expertise in women's reproductive health, obstetrics, minimally invasive surgery, and robotic assisted surgery. Join me each week as I interview guests in the top of their fields about the world of OBGYN, exploring the innovations and personal stories that shape our medical experiences. Hello, everyone. We are here in our podcast series called Conversations with Your Physicians and Nurse Midwife. I would like to welcome Dr. Shalja Dayal. Dr. Dayal has been with us for almost 5 years at Suncoast, and we are going to be discussing today polycystic ovaries, better known as PCOS. So let's start our conversation about PCOS. So let's start with the obvious. What is PCOS?
Thanks, Dr. Torres. So PCOS stands for Polycystic Ovarian Syndrome. It is a complex trait of unclear etiologies. It's an important cause of cardiometabolic risks, ovulatory and menstrual irregularities, infertility, and hyperandrogenism. The manifestations include androgen excess, ovulatory dysfunctions, and polycystic ovaries. It is known as one of the most common endocrine abnormalities in women, and it's estimated to affect approximately 10% of women.
So that's a large percentage, 10%. It is a lot. So how are we going to diagnose our patients and how we are going to counsel them?
Yeah, so PCOS is diagnosed with something called the Rotterdam's criteria. The Rotterdam's criteria indicates that if you have PCOS, you have 2 out of 3 of the following: oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries on ultrasound. So if you have irregular cycles, which are cycles that are longer than 35 days, or irregular intervals between your cycles, or not even getting your periods, or if you have signs of hyperandrogenism, which usually present as acne, facial hair growth, hair loss, then I would recommend that you bring up PCOS with your doctor.
Are there any labs that we're going to order for this diagnosis?
Yeah, so typically we're going to order a panel of hormonal labs, and we'd recommend that you get an ultrasound as well. Some of the lab tests that we order also rule out other causes of oligoanovulation or hyperandrogenism as well.
So when the patient comes to our office and she tells you, Dr. Dayal, my menses are very, very light, or I start skipping months, you're going to do these labs. How are you going to manage it?
For PCOS, after we get the labs done, we get the ultrasound done, that's how we're going to confirm if you have PCOS. Now, since PCOS is a very complex syndrome, the answer on how to manage it usually depends on what your symptoms are and what your goals are. So it depends on how old you are, if you're trying to conceive. And then if you're not trying to conceive, we usually do want to treat the menstrual dysfunction. And one of the best ways to do this is going to be with the combined oral contraceptive pills or birth control pills.
So what if I have risk factors to take the birth control pill? Are there any other alternatives for me?
Yeah, so there's a lot of other options for endometrial protection, including the progestin IUD, progesterone-only pills, or cyclic progesterone. All of these things will protect your uterine lining, which is one of our main goals with PCOS patients that have irregular cycles. However, if you can take combined oral contraceptive pills, those can be beneficial because they also can help reduce the signs of acne and facial hair growth and other symptoms.
So this facial hair growth or hirsutism is one of those symptoms of hyperandrogenism. So is there any other alternative that we can do to manage hirsutism?
Yeah, so I like to have the patients start on the combined oral contraceptive pill first, and we give them about a month or so, see if that helps reduce that facial hair growth. And then if it doesn't, or patients are still, having new onset of hair growth, then they can try a medication called spironolactone. We always recommend reliable contraception with spironolactone because it can cause risks to pregnancy.
Okay. That's a very, very good guidance for our patients. So there's other issues that having polycystic ovaries can cause on the patient. So what are they at risk for? What are we wanting to prevent on these patients?
Yeah, so PCOS patients are at risk for infertility, endometrial cancer, diabetes, high cholesterol, heart disease, depression, anxiety, liver disease, obesity, and sleep apnea. And I know all of that sounds really scary, but not every single patient has all of the following. So when you talk to your doctor about your symptoms, we'll discuss what your individual risks are based on your symptoms and your lab values, and we'll always individualize your care to help decrease these long-term risks.
Okay. So I always, when I see a patient with PCOS, I always say I need to protect the lining of the uterus
Mhm.
because they're at risk for endometrial hyperplasia. So how do you manage that, Dr. Dayal?
Yeah, so you are at risk of endometrial hyperplasia if you have irregular cycles or you're not getting your cycles. So, what we say when you're not getting your cycles is that you're likely having chronic anovulation, or these are long periods of times without you ovulating. When that happens, your endometrial lining tends to proliferate, and that causes something called endometrial hyperplasia. And that can long term increase your risk of endometrial cancer. And this is all just because of those hormonal imbalances of PCOS. So, because of that increased risk, is why we always recommend endometrial protection, which is basically some kind of birth control.
And one of the other risks of PCOS is infertility. And I always tell the patients when I diagnose them, the battle is not lost
Yeah.
because there's ways that you definitely can get pregnant. I would like for you to talk a little bit about how we manage this and if there's any natural way that the patients can do to, help with their fertility journey.
Yeah. And I think when people hear the word PCOS, they do just get scared of infertility because that's kind of what's out there. And that's what people are told. Like, if you have PCOS, you're going to have a hard time getting pregnant. And for some people, it can increase, it can cause difficulties in getting pregnant. But the majority of patients with PCOS end up getting pregnant if they want to. And we have tons of options for that. And we do individualize it based on the treatment, based on the patient and their symptoms. But one of the most commonly used medications for anovulation is letrozole, or there's also another medication called Clomid. And when you ask about natural options, so we always, always, always recommend leading a healthy lifestyle. And this is going to include increasing exercise and movement and incorporating a healthy diet into your lifestyle. It's proven that if you are to lose about 5 to 10% of your body weight, that can help return your body to ovulation. So you could start having regular cycles in a natural way by losing that weight. This can be more challenging for PCOS women, and there's no one-size-fits-all recipe for losing weight. The general principle is, of course, to decrease your caloric intake and move your body more. We do encourage meeting with a nutritionist to help meet your goals. And while it's not clinically proven, there are many supplements that are suggested to help with PCOS. One of the most commonly used one is inositol.
Well, thank you very much for all the information that you have provided to our patients with PCOS, and thank you for being here in our podcast.
Of course. Thank you for having me.